and treat adverse events of fillers. My name is Dr. Treacy. I'm from Dublin, and I have no financial, I suppose, association with any company that's mentioned or involved in this lecture. If we look first at the different facets of being a doctor in terms of preventing this, one of the first one is obviously experience. Experience of the doctor themselves. And experience teaches cosmetic physicians or cosmetic surgeons to become good, but avoiding and treating adverse events makes them great, technically. And in no area is this truer than in the whole field of aesthetic medicine or cosmetic procedures involving neurofillers and neuromodulators. And with experience comes knowledge, and by utilizing knowledge both of the anatomy of the patient but also of the materials that you're using. So if this a well-trained physician then using knowledge should be able to not only reduce the possibility but also, if something does happen, by acting promptly and using a particular methodological approach to the problem. So we can see that within the face itself, a lot of the sort of danger areas are here: facial nerve, alar artery, supratrochlear, supraorbital, superior labial. So these are all ones that we sort of should be careful of. Now, a couple of years ago, Pierre Nicolau in MCAS drew my attention towards arteries that are emerging out of certain areas, like the infraorbital, and ones that are fixed in certain areas, like the alar or the facial. And I'm going to look at Pierre's lecture just in a moment. The next thing, obviously, we have to take into account is GDPR and consent. So each injection contains some degree of risk, and the patient should be informed of these risks, including the possibility of blindness happening. Now, common things that happen would say like bruising, erythema, pain. We obviously put those in our consent form, and they'll pass over very quickly. But some of the true complications, that's scars, infections, granulomas, lumps, ptosis, that my colleagues are talking about today, including vascular occlusion, they're the things, I suppose, that really need to be on your consent form. In terms of different fillers, we know that different ones have different strengths, characteristics, binding agents, and as a consequence, we should get to know our products quite well and in the area we use them, and then obviously also the anatomy of the blood vessels and the nerves. Be careful also to take a good history from the patient. This patient here would say after a rhinoplasty, if she came in for a non-surgical rhinoplasty, we'd have to be obviously aware of her previous procedures. Then obviously past medical history, including autoimmune diseases, is important as well. Though I must say, in 20 years of practice in aesthetic medicine, I've never really seen a problem with aesthetic complications secondary to autoimmune disease. I've treated many patients, particularly patients with, say, with rheumatoid arthritis, that never had a problem. I probably would be careful of steroid because it involves the skin. This is to reduce complications in terms of using the smallest needles possible. So this is a 30 gauge, and we know that most of the fillers come with their own needles, and also we should try and slow down and spend about 5 to 7 minutes on each mil of product that we're using. In terms of anesthesia, we tend to make up our own, put it on 20 minutes beforehand, and be aware that this can increase the risk of complications secondary to vasodilation. In terms of whether to use cannulas or needles, I must say I use both. If I'm using, I suppose, the teardrops, if I'm fixing them, I tend to use a cannula. If I'm doing temple area, I tend to use a needle. And I suppose for most nasolabial, even though some people tend to go down supraperiosteally, I tend to use a needle to go in, I suppose, mid-dermis. And also I tend to use it on lips. That's a personal choice. To be aware that just vascular compromise that occurs in terms of macular blindness, its rate is very low. It's 0.05% as recorded. So if we look at the different arteries in the face, we have to know obviously where the facial artery is and its branches, including the alar, superior and inferior labial, also the trochlear. And as I mentioned, Pierre earlier mentioned, broke these arteries down into emerging points, such as the supratrochlears, the infraorbital, mandibular, these black areas, and then fixed points, the facial artery, the temporal, the angular artery. And basically what he was trying to get across was the arteries with fixed tend to be the ones that are involved in complications, and the ones with emerging points don't tend to be, or at least quite rarely. And that to me was differentiation. I'm going to look at 5 or 6 danger areas in the face that we should be aware of. Obviously, the labella involving the supratrochlear and the supraorbital is one, so we have to be careful. This starts off deep, but it makes its way sort of superficial. Both of the vessels tend to. The second one is one I use here, Julie Bass. She's a nurse in California, and Julie was kind enough to allow her pictures to be used in complications back now 10 years ago. And I suppose it was a brave thing to do at the time, because a lot of people didn't mention complications until we brought it forward, I suppose, at IMCAS about 2011, 2012, and Julie in happier times in Dublin after her face had obviously settled. Facial artery, just to be aware of it, making its way up, and also, I suppose, if we're using a product in terms of a vascular area, then it should be a reversible one. This is a non-reversible one. Patient that presented to me in Dublin with RAS after compromising her nasolabial area, believe it or not, even though it's retro behind it as well. It was an alar necrosis that we're facing. The patient did survive, believe it or not, and again, be careful of the lateral nasal. As we mentioned earlier, you can get compromised there, particularly the anastomosis back into the retinal vessels and ophthalmic artery. Again, this patient from Colombia that we've seen with compromise to her nose after getting a polyacrylamide filler to the area. This is just the arterial supply, I suppose, to the lips in terms of the superior and inferior labial, and to be aware that the wet-dry zone, that the labial artery is just directly underneath it, and as a consequence, you can almost feel pulsatile. Don't tend to sort of inject, I suppose, to get anterior projection in the posterior area, always do it from front. And again, this is showing that the inferior labial artery normally runs medial of the surface of the bicularis. These are some of the complications we've seen over the years. We have lots of lips ones. Most of these are bruising. And I suppose we have to be careful of lips. I suppose they're certainly among the most common complications that I see is lips. The risk of blindness. I've just been involved in 2 cases with blindness, one in the UK and one in Sweden. And in terms of the one from Sweden, the doctor had only used 0.2 mils, believe it or not. This is a schematic diagram of how, I suppose, possible antegrade or retrograde flow of fillers can make its way from, would say, the angular artery all the way into, I suppose, the ophthalmic artery, and particularly the supratrochlear ones, where the anastomosis exist. Another danger zone that I want to look at is the temple area, and in a moment I'm going to show you a nice video of a colleague of mine and ours, Arthur Swift, how Arthur sort of finds his sweet spot. I use it all the time to inject into the temporal area. Be careful, I suppose, of the facial nerve runs up across there, but also, I suppose, the temporal branch of the facial nerve just here, and the superficial temporal artery just above it. which can easily be, I suppose, primed.
In the temple region, you have the superficial temporal artery that's coming up, and it gives off a branch over here called the frontal ramus. That's the one that you can feel your pulse in your temple. And when it comes across, it's going to avoid the supraorbital, and it actually likes to join up to the supratrochlear. But that's a highway to go right this way into the eye, and there have been 4 reported cases of blindness here in the US. 2 are temporary, 2 have some permanent loss because they hit that vessel. 1 centimeter up the temporal fusion line. You feel for the temporal fusion line. You go 1 centimeter up. You come 1 centimeter back following the orbital rim. This is your sweet spot. With that injection, you go right down onto bone. You put your finger over it to make sure there's no pulse because you would prefer not to skewer the artery if you could avoid it, but I've done it. And you'll see the product flow here and stop because it's fused. You'll see the product flow down to the orbital rim and stop because it's fused. And then the only place it can go, because I'm not allowing it to go here, you'll see it push against my finger, I won't let it, is it will come down this way right into the hollow of where I want it. I will not stick a needle under the skin over here. This is very dangerous.
So again, the transverse facial artery we have to be careful of. It's quite easy to pregnate also. And I've had many cases, I suppose, of this. It's a branch of the superficial, I suppose, temporal artery making its way up. These are the sort of problems that you'll get. And unfortunately, this is an interesting case that sort of was presented to me, where the patient had this reticular pattern from the transverse facial, and I had followed this on FaceTime, and I'd asked her to inject in 750 units of hyaluronidase each day, and on the 3rd day it had practically disappeared. This is a problem that I had myself, believe it or not. I was writing a paper on atrophic acne scarring using Aeas with this patient, and the patient developed this pattern almost before my eyes. Within a few days it had became like this and almost necrotic, and but the patient actually recovered and was fine.